Hello everyone, tips and tricks of RIRS in diverticular stone management. Caliceal diverticular are non-secreting urothelium cavities. First case is a 1.5 cm lower caliceal stone which can be seen on this contrast enhanced CT scan. Initial flexible ureteroscopy was done, but we are not able to find any opening of the diverticular. A CM image here demonstrates that the stone lies in the lower calyx and with a fanned shadow. RGP was done, which was suggestive of lower caliceal diverticular stone. We instilled methylene blue into the calyx and then flushed with saline. Later we can see the methylene blue effluxing from the diverticular opening. We can see the efflux here, which is jetting out through a small diverticular opening, which probably we would not have seen without instilling the methylene blue. Once we are confirmed about the diverticular stone with the help of CM images, incision was made at that side and then we could see the stone easily. The stone were broken with the help of TFL laser and the fragments were retrieved. This is post-surgery RGP image which shows no extravasation and cleared stone. Second case is a diverticular stone which was identified with the help of mucosal edema seen around the neck. Here we have around 12 mm of diverticular upper caliceal stone which can be seen well on contrast CT scan as well. Initial flexible ureteroscopy was done which shows a edematous mucosal opening in the upper calyx, which was again confirmed with the help of intraop CM. Once the site of stone was confirmed, the opening was enlarged with the help of laser and the stone was localized. Then the procedure was quite simple. The stone was fragmented into small pieces and removed. We can see here the stone is being popcorned into small tiny fragments resulting in golden dust, and the stones were flushed out of the diverticular opening. Third scenario is a diverticular stone covered completely with mucosal cover. Here we can see 9 mm middle caliceal stone. Sorry for the dots on the scope. The stone was not seen. Only a thin pale bluish membrane was seen, which we can well appreciate here. And based on the CM findings intra-op, slowly the laser was used to pulverize the mucosa over it. And once the mucosa was peeled off, we could see the stone, which was later fragmented and removed. Scenario is a diverticular neck incision. We can see a 9 mm stone in the upper calyx. A thorough flexible ureteroscopy was done, but we are not able to find any opening there. Later we could see a small tangential opening which was going tangentially from the upper calyx. We could confirm this with the help of intraop CM. With the help of laser, the opening was enlarged. Then we could find the stone which was located deep inside the calyx with a long infundibulum. With the help of laser, we pulverized the stone into small fragments which were later flushed out of the calyx and removed. You can see in the CM image the cleared stone. A RGP was done which showed no extravasation. Fifth scenario is ECIRS, where supine personnel came to our rescue when we are not able to reach the stone with the help of flexible ureteroscopy. Here we can see two 9 mm stone located in the upper calyx diverticulum, which is quite dilated. We did a flexible ureteroscopy, but due to angulation there, we are not able to reach the stone, and since the cavity was large, we thought supine personnel may be a better choice to dilate, because even if we clear the stone may lie in that cavity. We can see the angulation here in this image. So supine personnel was done to clear off the stone. So ECIRS came very handy in this situation. So the take home message is we should have high degree of suspicion of diverticular stone when we see an isolated caliceal stone. Different signs like mucosal edema, blue dot sign or a tangential opening can give a clue about diverticular opening. Correlating with RGP and CM images is very useful. Good pre-op counseling regarding need for PCNL or inability to remove the stone is necessary. Thank you.